I'm sure that the vast majority of stroke survivors like myself and our carers are eternally grateful for the care we received from all the health professionals who looked after us during our time in the acute care and subacute care hospital system. But we all know that it is impossible for those health professionals to continue to provide that care once we are discharged from hospital. And I'm sure all professionals frequently wonder how their former patients are getting on, even years after they've been discharged to live in their communities. So, what I want to talk about here is what happens after stroke survivors and their carers return to their homes to start the long process of rebuilding their post-stroke lives, and what needs to be done to ensure that all the work done by health professionals in the hospital system to start us on that long stroke recovery journey is not wasted. One can look at the stroke recovery journey travelled by stroke survivors and their carers as a continuing care pathway, which has three distinct stages. Firstly, there is the acute care stage, which commences immediately after the stroke occurs. It includes the ambulance trip to the emergency ward of a local hospital, the initial diagnosis of the cause of the stroke, the administration of TPA drugs if appropriate, and the stabilisation of the medical condition of the stroke survivor. The subacute care stage commences when the stroke survivor is transferred to a stroke rehabilitation facility where intensive physiotherapy, occupational therapy, and speech therapy occurs with the aim of recovering enough functionality for the stroke survivor to be safely discharged back into their community. And the community care stage, which commences when the stroke survivor is discharged from their rehabilitation facility to live in their own home or in appropriate supported accommodation. It is then that the responsibility for ongoing care is transferred from the hospital system to the community care system. According to statistics published by the National Stroke Foundation, About 60,000 people suffer strokes in Australia each year. This represents about 0.26% of the Australian population, and about 72% of these strokes are first-time strokes. Of these 60,000 people, about 20% die within a month of having a stroke, and 33% live less than 12 months after their stroke. About 88% of stroke survivors live at home, most with a disability. Based on these figures, one can conclude that each year there are about 35,300 additional stroke survivors being discharged from hospitals to live at home in their communities. And if we accept that there are about 350,000 stroke survivors currently living in Australia, we can estimate that about 35,000 stroke survivors, or about 10% of the total number of stroke survivors, or 0.15% of the Australian population, are less than 12 months post-stroke and are either still in hospital or have been newly discharged to their homes. This means that there are about 315,000 stroke survivors, or about 90% of the total number of stroke survivors, or 1.37% of the total Australian population, who are greater than 12 months post-stroke and are living in Australian communities. These statistics can be summarised in this figure. It shows a timeline which starts at the time of the stroke and admission into an acute care hospital, followed by transfer to a subacute hospital and eventually discharge to live at home in the community. Over this time, we see how the nature of the support required gradually changes from clinical support to non-clinical support. Now, if we draw an arbitrary line at 12 months post-stroke, we can divide the stroke recovery journey into two phases based on the relative importance of the roles played by clinicians and non-clinicians. This gives us what I like to call the clinical phase and the post-clinical phase of stroke recovery. Now, some stroke survivors will progress rapidly through the clinical and post-clinical phases on their way to a full recovery. But other stroke survivors will progress much more slowly and get stuck in the clinical phase because they have disabilities that require significant clinical intervention for the rest of their lives. So there are roughly 35,000 stroke survivors, or 10% of the total stroke survivor population, who are on the clinical phase side of that line, while there are about 315,000 stroke survivors, or 90% of the stroke survivor population, on the post-clinical phase side of that line. This illustrates very clearly that the first 12 months post-stroke is critical from a clinical point of view. But that focus gradually changes to a point where stroke survivors and their carers enter the post-clinical phase of their stroke recovery, which is largely dependent on people playing non-clinical roles within the community care space. This diagram illustrates the changes in a person's quality of life following a stroke and during the early stages of their long stroke recovery journey. Firstly, the quality of life drops catastrophically immediately following a big stroke as physical, emotional, mental, and communication capabilities rapidly decline. Then, as the acute and subacute professionals get to work, some of that functionality recovers, and the stroke survivor's quality of life slowly returns until the survivor is discharged back into his or her community. But what happens next not only depends on the fighting spirit of the survivor, but on the level of community support the survivor gets in the months and years that follow. Let's consider two possibilities here. In the first case, the survivor receives poor post-clinical support with limited access to community services to help rebuild his or her post-stroke life. What we might expect to happen here is that there is an initial increase in quality of life as the survivor continues to regain functionality. But things eventually become just too hard and the survivor sinks down into their own big black hole and a lowered quality of life. In the second case, the survivor receives good post-clinical support with good access to community services to help rebuild his or her post-stroke life. What we might expect to happen here is a continuing increase in quality of life as the survivor discovers new activities that make use of recovered functionality and provide pleasure and meaning for the remainder of their post-stroke lives. Let us now look at the respective roles of clinical support and post-clinical support in the success of a typical stroke recovery journey. First, let's look at the objectives of clinical support in both the hospital system and the primary healthcare system. Obviously, the main clinical roles are related to addressing the clinical needs of stroke survivors while they are still in the acute and subacute care hospital system, but also in the primary healthcare system. Another important clinical role is to prepare stroke survivors and carers for life back in their communities. But primary health care clinicians must eventually discharge stroke survivors and carers to some ill-defined community care pathway. As more stroke survivors get discharged from hospital and require attention, and as the funding for clinical services and care packages terminate. Regrettably, clinicians have no option but to offer an encouraging good luck mate at the end of their last package-funded appointment. Let's now look at the objectives and roles of post-clinical support that must take over from the clinical support provided in both the hospital system and the primary healthcare system. In an ideal world, the objectives of this post-clinical support must be to support all stroke survivors and carers living in Australia, including those who are already living in Australian communities, plus those being discharged from subacute hospitals. To monitor and improve the quality of life of both stroke survivors and their carers. To keep stroke survivors and carers well informed about stroke recovery issues and to keep them out of hospitals wherever possible. Post-clinical support must promote self-management by survivors and carers. It must connect stroke survivors and carers to appropriate community and health services, and also to peer support groups. And it must reduce the demand for clinical services by stroke survivors and carers in both the primary healthcare and hospital systems. So who could play these post-clinical support roles in the community? Clearly, it can't be the clinicians and allied health professionals in the hospital or primary healthcare system who are already overworked. But they could be played by the many people living in the community who have what can be described as a lived experience of stroke. In other words, these people would offer post-clinical peer support. These peer support people would need to be trained to work cooperatively with clinicians, and especially to be able to earn the respect of clinicians, to understand clearly when clinical decisions are required, and be able to play a coordinating role where necessary. They would also need to have a good understanding of stroke rehabilitation therapies and have effective tools to monitor stroke recovery. They would need to work with a stroke survivor and their carer to set meaningful recovery priorities, and to have good peer coaching or mentoring skills, and to have access to stroke education resources and access to local service availability information. So what would be needed to enable this post-clinical peer support to happen? Firstly, the concept of quality of life must be the key driver of post-clinical peer support. Hence, the ability to measure quality of life of both stroke survivor and carer is critical. But unfortunately, current clinical quality of life measures are totally inadequate because they are specifically designed for clinical purposes, not post-clinical or peer support purposes. And it will be necessary to monitor a survivor's quality of life regularly until a satisfactory quality of life is attained. The quality of life measure must identify issues of greatest concern to the survivor and/or the carer, as opposed to the issue of greatest interest to the clinician. These issues may include physical, mental, cognitive, and communication disabilities, relationship, social, financial, employment, or retraining issues. The quality of life measure must be able to detect the emotional impacts of any of these stroke-related disabilities, and it must identify differences in concern between a survivor and his or her carer. The quality of life measures must also help peers to identify the evolving information needs of survivors and carers, the medical and community services needed by survivors and carers to address the issues of greatest concern, and the self-management plans that need to be developed for both survivors and carers. So, we specifically need a stroke quality of life survey that can provide a standardised method of monitoring the quality of life of stroke survivors, and is based on the activity and participation section of the ICF framework that helps clinicians, therapists, and peer support team members to focus on the issues of greatest concern to the survivor and carer throughout their entire post-clinical stroke recovery. That helps determine the efficacy of clinical and therapeutic interventions, that links specific quality of life responses to specific sources of information, local service availability, and the need for clinical and therapeutic interventions. That groups stroke survivors and carers into specific special interest groups based on their quality of life responses, where they can discuss issues of common interest amongst themselves and relevant professionals. That facilitates the construction of stroke recovery stories that can inspire other survivors and carers, and that encourages stroke survivors and carers to become peer leaders and coaches or mentors. We also need a special stroke self-management program that is based on standard self-management programs, but is modified to reflect the lived experience of stroke survivors and their carers. That self-management program needs to address the self-management needs of both survivor and carer, and it should be delivered in both classroom and online settings. It should be customizable for individual survivors based on their stroke quality of life survey responses, and it should support the development of action plans based on those responses. The program should also support the measurement of changes in quality of life following the completion of action plans and keep survivors and carers focused on the specific stroke-related issues of concern. Finally, it should prompt survivors to record and share their stroke recovery stories. Before I conclude this presentation, I would like to outline very briefly just how powerful the proposed peer support tools could be and how they enable people with lived experience of stroke to assist their fellow stroke survivors and carers. As I've already mentioned, the basis of this peer support tool is a specially designed stroke quality of life survey. This quality of life survey contains a number of questions relating to each of the 14 sections in the activity and participation and environmental issues section of the International Classification of Functioning and Disability, published by the World Health Organization. Each of these survey questions may be responded to in a number of ways which indicate the level of concern, recent changes, priority for action, emotional impact, and the desire to self-manage specific disabilities or environmental issues. Each response may be linked to one or more rules, which can be defined by health professionals, including research workers and experts in acute, subacute, or community care. These rules may link specific survey responses to information in the form of fact sheets, websites, videos, or podcasts that contain information relating to that particular response. This means that stroke survivors only receive the most up-to-date information that relates to their own specific concerns. The names of local providers of services that address that particular stroke recovery issue. Links to actions such as notifications to members of the survivor's medical support team, or even the issuing of requests for appointments or video conferences to discuss a particular stroke recovery issue of concern. The inclusion of stroke survivors in special interest groups relating to a specific medical or community support issue. The development and monitoring of action plans that address a specific medical or community support issue that can be completed at the survivor's home. In theory, the outcomes of these action plans can become part of the survivor's medical record and help inform clinicians and others about the effectiveness of particular therapies or activities. This slide illustrates how the capacity of the Stroke Quality of Life Survey to group survivors and carers into special interest groups will assist in building long-term bridges between the stroke survivors and carers community and health professionals and community health providers. Firstly, we show the stroke survivors and carers who are living in their communities. And the health professionals and research workers attached to various medical research institutions, acute care and subacute care hospitals, and community healthcare providers. If we design the Stroke Quality of Life Survey to identify the many possible stroke-related disabilities that may be of concern to stroke survivors and carers, then we can define special interest groups that focus on each of these stroke-related disabilities. By getting stroke survivors and their carers to complete the Stroke Quality of Life Survey at regular intervals, it would be possible to direct individual stroke survivors and carers to special interest groups where they can share their immediate concerns and experiences. This would allow health professionals and research workers to link into the special interest groups of special interest to them, whether that interest is from a research, acute care, subacute care, or community care perspective. I believe this kind of networking based on common disability-related interests will become a powerful mechanism for building bridges between health professionals and the people who benefit from their professional expertise. All of this is possible provided the Stroke Quality of Life Survey is properly designed and fully integrated into the post-clinical peer support tools I have been talking about. But this can all happen if, and only if, the whole stroke industry start to take the needs of stroke survivors seriously for once. I will conclude this presentation by suggesting that in order to provide effective post-clinical support for stroke survivors and carers, people with lived experience with stroke need to be mobilised to become peer coaches so that stroke survivors and carers can be properly supported once they are discharged from clinical care. To do this, peer coaches will need new 21st century stroke peer support tools which are accessible to all stroke survivors and carers regardless of their locality or post-stroke duration. These tools should facilitate the delivery of stroke-related information specific to each individual stroke survivor and carer, and all stroke survivors and carers living in a specific community, region, state, or country. These tools should facilitate the self-management of individual stroke recovery journeys, and they should monitor quality of life over the long term and initiate appropriate information flows when and where they are needed, and automatically trigger either local or centralised actions according to rules defined by clinicians and other health professionals. Thank you.